I think one of the common themes in all of rehabilitation, maybe in all of medicine now, I'm trying to come up with predictors of who will respond and who will not respond, so-called responders and non-responders, to take that image into the question you've asked. Given the fact that someone may have had a stroke for a certain length of time, does that mean that they can't recover? Does that mean that their brain is no longer plastic? Or is there an opportunity to relearn, to retrain one's brain? Well, we spend a lot of time trying to come up with predictors, who will succeed and who will not. And many of us have found that, so with respect to the upper extremity of stroke survivors, we know that if the patient presents with certain movement potential capabilities, irrespective of the length of time following stroke, then the prospects for improving further, that which is a very vague term, but being better than you were when you first walked in after a certain number of sessions of therapy, is there. What do I mean by that? We know that patients, I told you earlier, who showed this so-called flexion synergy. I'm exaggerating now. The shoulder is brought in, the elbow is bent, the wrist and fingers are bent tight. And it's very difficult for some of those patients to break this flexion synergy. Those patients who have no movement at all and some time has gone by, it's highly unlikely that most of the interventions that we know of today are going to succeed. However, for those individuals who can begin to show some movement, straightening out the elbow, extending the elbow, beginning to raise the wrist, and beginning to open the hand, as though you're starting to, I always say, wave goodbye to someone, that image. We know that those individuals still have some machinery that will allow these muscles that have the opposite function of these flexions and closures to be built upon. That's why the two things I always do whenever I screen patients, the first thing I always do is when I meet them for the first time, I don't care if it's the left arm or the right arm that's impaired, I always shake hands with the impaired arm, because I want to see spontaneously whether there's any movement out of this position towards straightening out the elbow and opening the hand. I'll already have an indication before any words are spoken as to what that person's potential might be. The other thing we look for in interviewing a patient during our initial screening is I always like to have patients sit on their less impaired upper extremity. So when they choose to talk and gesture, I can look at the movement patterns of their impaired limb, because gesturing, unless it's a very deliberate movement in which we know we're pointing our finger at someone, I dare say most of us cannot tell at all what we've done in movement of our arm and hand to articulate, to gesticulate as to what we're trying to do. But that does tell us that this subconscious ability to move can be built upon in a very positive therapeutic way.